You are listening to the Fertility Talk series hosted by Blessed Brokenness, a 501c3 bringing spiritual healing and financial blessings to those who suffer from infertility and child loss. Blessed Brokenness serves the community through in-person and virtual faith-based small groups and scholarships for fertility treatments and grief counseling. We hope you will subscribe to our channel and learn more about our ministry and how we are helping men and women find hope and healing through God's Word. We will go ahead and kind of jump into introducing Dr. Karen Hammond. I think most of you all know her, but she is here at American Institute for Reproductive Medicine of Alabama in Birmingham, and she also sits on the Blessed Brokenness board, and we have loved having her support Blessed Brokenness in this community. She's been through, how many years have you worked, if you want to share? Years. She is an expert in this field and has so much knowledge, and we always ask her to join us because we just know how much you guys love hearing from her and how much information you're able to receive from her, and everybody loves having the Q&A at the end because it truly is like a free consult for you all, being able to ask directed questions and really get that time with the doctor that, and you don't have to make the appointment, and that's so great for us to be able to share with you guys and support you through this journey. So we just appreciate you guys jumping on. And what we will do now is we'll go ahead and get started. Karen, like I mentioned, she has a lot of great information on causes of early pregnancy loss. I think she's going to focus on the first trimester. And so she's going to walk through some causes and kind of what to look for in ways to maybe prevent, if possible, or at least be aware of these issues. And then at the end, like I mentioned, a Q&A, and then we'll do a giveaway. So again, don't forget to let us know who you are or give us a wave, a high five, whatever emoji you'd like to throw out there, and we will put your name into the drawing. So without further ado, I'll let Karen get started.
Thank you.
Thank you.
Thank you for inviting me to do this, and thank you all for joining us on a school night, a work night, and hopefully again I can give you some information, to improve your knowledge, to improve your comfort, and to also to give you hope, because the news is not all bad, even if you've had pregnancy loss in the past. So I like to start out thinking with definitions, and the first definition is what is a miscarriage? What is a pregnancy loss? Well, theoretically, by medical definition, a pregnancy loss can happen at any point in the entire pregnancy. But for a miscarriage, it's generally considered to be a loss prior to 20 weeks of pregnancy. And it's more common than you might ever think. Up to 20% of pregnancies end in miscarriage. It's pretty amazing when you start thinking about this, that many pregnancies are lost before the woman ever knows she's pregnant. Women that are trying really hard to get pregnant are kind of slaves to the stick and doing frequent pregnancy tests so they know very early. And women that are undergoing treatment in a fertility practice will get early HCG levels. So they know much earlier than women just walking around and, oh, wow, they're pregnant. And believe it or not, that really does happen. So 20% of all pregnancies end in loss. The further you get, the less likely it is to occur. The risk goes way down once you see a heartbeat, but sometimes bad things still happen. And unfortunately, bad things still happen more than one time. About 5% of women will have more than one pregnancy loss. So that leads us to the next definition of recurrent pregnancy loss. And used to be that definition was defined as more than 3 pregnancy losses or 3 or more losses. But now most people think, oh, an evaluation is warranted with just 2 pregnancy losses. In my opinion, you should start with the least invasive, least expensive evaluation means and work up until you find out what's going on. Also, just because you find one issue doesn't mean there's not going to be another. So that's important to keep in the back of your mind too. Some of these tests can be very expensive. Some of the tests are controversial. Even people in our field don't agree necessarily on what tests should be done, what abnormalities are really real, and what should be treated, and even how they should be treated. So it might be worthwhile to ask your provider and maybe get a second opinion. Ask the advice of other respective practitioners that you might encounter. So anytime you have a medical concern, you want to start out by giving a very detailed, careful history. So not only do you want to know how many times that you've been pregnant, you want to know how many losses you've had, how far along the pregnancies were, was a heartbeat seen, was any evaluation done, did you have regular periods, any other health issues. We'll talk about it as we go along, but there are a number of health issues that can contribute to having a pregnancy loss. Also want to do a family history. If you've ever seen me, you will have probably remembered that I asked you if you or anybody in your family has a history of pregnancy losses, infertility, genetic disorders, or birth defects. Because some of these things run in families. They can be genetic, and if you have an issue with that or a family history of that, we want to stay on top of it and try to rule out or find out what those causes are right off the bat. The next thing is going to be about your social risk and your kind of your daily habits. My daily habit and drug of choice is caffeine, and I love coffee. I could drink coffee all day long, and I have to, even though I have a coffee maker in my physical office, not just in the suite, but in my office on my desk, just in case I have a caffeine emergency. It's not so good when you're trying to get pregnant to have excessive caffeine. Other risk, we'll kind of go through certain medications can put you at risk for a pregnancy loss, and certain other physical abnormalities can. Then we might want to think about evaluating your uterus, because as our uterus develops, when females are still in their mother's uterus, there are lots of changes that occur, and there can be breaks as the development of the uterus is occurring. So sometimes that will cause abnormalities of the uterus. Other times age or time or previous infection or coincidence can happen that can cause uterine abnormalities. And then finally, I mentioned already that we'd want to do a careful family history. There can also be genetic things that we'd want to look at, such as your chromosomes, or perhaps the chromosomes of a pregnancy that's lost. So let's go through these things step by step. If you have questions, feel free to throw them in along the way, and I'm happy to address them as they come up. And Mallory and our lovely Ann, who is off camera, will be happy to direct those questions to me. So let's start out talking about genetic causes. If you had to find one cause, the most common cause of a pregnancy loss, it's probably going to be some degree of a genetic abnormality. It can be that one or even both of the parents have a genetic disorder that you may or may not know about. We all have 23 pairs of chromosomes. 22 of them have numbers. The 23rd pair is either going to be two X's or an X and a Y for a female or male, respectively. Sometimes the little arms of the chromosomes, they kind of look like a rounded X. Sometimes the arms and legs can be swapped up, causing a translocation that can cause a pregnancy loss. Or it could be that the male or the female has a translocation or is missing part of a chromosome, and that can be passed along to the pregnancy. Even if those things are completely normal, the pregnancy can develop and still be missing or having a translocation with a chromosome, one or more chromosomes. Some of the more common ones are trisomies. I'm sure you're familiar with Down syndrome, where there are 3 chromosome 21s, or sometimes it might be a monosomy, where there's only one chromosome. The most common one of those is Turner syndrome, where there's only one X chromosome and there's not a second sex chromosome, an X or a Y. And sometimes there are multiple chromosomal abnormalities. So this can either come from the parents, it can be a family inherited disorder, or it can be caused from fertilization and development. Many of these things you won't know until a pregnancy loss occurs and genetic testing is done. The next thing I want to talk to you about are uterine abnormalities. So I mentioned before, without giving you a whole science lesson, that there are, as we develop when we're still in utero, our uterus starts out as having two horns. So it's two separate, like a cat. If you took anatomy in school and had to dissect a cat, it has two horns to the uterus. And here's my graphic for that. It starts out looking like that with two horns. And there can be a couple of different ways it can go. So this shows two horns that are separate. So that's a bicornuate uterus. Oops, wrong way. Kind of hard doing it backwards. So it can be a bicornuate uterus. It can be a duplication of the uterus, where they're not just, boy, that's hard to go backward, where it's two horns, two cervices, and even two vaginas. Or it can be where there's just one horn that develops. Or it can be where there's a septum. So it's just like that little part that holds your top lip to your gum. There's that little septum there. You can have a septum that goes down in your uterus, and it can go all the way down your vagina. So, and that word was for you, Rodney.
I was thinking the same.
I'm sorry. The chairman of our board is kind of still cringes when I say the V word. But all of these disorders can cause problems with implantation or pregnancy development. So that may be that's definitely something that we should take a look at early in the evaluation. The way you do that can be with an ultrasound, maybe a hysterosalpingogram where some fluid is put into the uterus, some dye, and you can watch it spill out the tubes. There's Rodney laughing at us. Or it can be with saline put into your uterus and a careful ultrasound done. There can also be some other uterine issues, and I have yet another graphic for you, which is on the last page here. And I'm sure you're familiar with these things, like a uterine fibroid. So a fibroid is a smooth muscle tumor. It's the most common tumor in women, and it can develop any place in the uterus. So if this is the uterus right here, that's the cervix, and you can have like a septum, like I mentioned. You can have fibroids that can actually push up, go a little bit closer, they can push into the lining of the uterus right there, or you can have like a little polyp. There's a picture right there, which is kind of like a skin tag that comes down into the uterine cavity. If you have any of those things, they can actually act like an IUD and keep a pregnancy from implanting, or they can set up infection, not necessarily bacterial or microbial infection. It's just like some inflammation and irritation. Or if the pregnancy implants on one of those abnormal areas of tissue, then it may not implant normally or completely, and it can interfere with how the pregnancy grows and develops. So a careful evaluation of the uterus is one of the earliest things after doing the history. So we talked about the Mullerian defects. So those are the ways that our uterus develops when we're still in utero. We talked about fibroids, and we talked about polyps. Some Mullerian defects you can fix, like a uterine septum. You just go in and clip it. It's a relatively simple surgical procedure. Fibroids can be removed, and polyps can be easily removed. It's amazing how frequently I see polyps. I saw a wonderful patient today who came in. We knew that she needed to have IVF. She came in specifically for that. And I always take a look at the uterus to make sure things are perfect before we put embryos in. And sure enough, she had a nice big polyp in there. We want to take care of that before she even tries to get pregnant, to try to avoid her having a pregnancy loss.
Karen, I got a question.
Sure.
So with the uterine abnormalities, can you, like with the septum, or is there a most common one? And can you still get pregnant with that, or is there typically a surgery that has to happen?
You know, you still can get pregnant with that. And I've seen lots of patients who have a baby successfully, and they come in and they have problems getting pregnant again, or they have a miscarriage after their first, after they've already had a child. So these things can happen. Pregnancies can go ahead, but we know that pregnancy loss rates are increased if there is one of these disorders, or we know that pregnancy chances are decreased. So we would want to know that and take care of it in advance to try to preemptively keep that from happening.
Okay.
Great question. Great question. The next thing I wanted to talk about are just some habits. And I already mentioned that my vice is caffeine, coffee in particular. It's recommended. Some people say no amount of caffeine is good. Most people agree, yes, AMs didn't like that either. Most people agree that it's probably no more than a couple cups of a caffeinated beverage a day. And if your cup is gallon size, that's not what it means. A cup is 8 ounces, so you want to probably limit to 2 8-ounce caffeinated beverages per day. Smoking, I can give you every reason in the book not to smoke. If you're a smoker, you know it's not good. If you're not, you know it's not good, and I'm going to tell you, too, that it's not good. It's well established that women who smoke have a longer time to pregnancy and a higher risk of miscarriage. So no amount of smoking is okay. And that includes any kind of smoking. That includes cigarettes, it includes marijuana, it includes vaping. All of those things we know are bad not only for pregnancy, continuing a pregnancy, but also for general health and life. And you certainly don't want to have a child that ends up smoking. Most people who smoke, one or more of their parents smoked. Alcohol use, again, it's all things in moderation. There are studies that have shown that more than 4 alcoholic beverages a week increase the chance for miscarriage. And this is prior to, it's early in the pregnancy, maybe even before that you know that you're pregnant. I tell patients that an occasional alcoholic beverage is fine, not an occasional bottle, but an occasional beverage. And most clinicians agree that it should probably be 2 or fewer alcoholic beverages a week. The other kind of lifestyle thing is body mass index, our weight. The body mass index is a way to calculate the normalcy based on your height and weight for your body size. There's some drawbacks to that, but nevertheless, it's probably the best means we have instead of just looking at the number of pounds somebody weighs. We know that for every point, that the normal BMI is between 20 and 25, but I think it's probably 20 to 30. We know that for every BMI unit above 30, the pregnancy loss rate increases by 1 to 2%. So you want to not smoke, you want to not drink very often, you want to have a healthy diet and a healthy BMI, and you want to avoid exposure to certain chemicals. So it's mostly the women that are impacted by this, and certainly in pregnancy, but hairstylists have a little bit higher pregnancy loss rate, and so do dry cleaners. So and there are other occupations as well where you are around chemicals all the time. So you want to try to minimize your exposure to those things. It's probably helping people in certain professions that we're wearing masks more and more frequently. That's very protective. The next thing that we'd probably want to talk about would be clotting disorders. The next 2 things, clotting disorders and immunological problems. So clotting disorders are things like protein C, protein S deficiencies, factor V and factor II. A really popular one that in our field that we're still debating what the right thing to do is MTHFR. It's a mutation people can have that causes vitamin B deficiency, better known as folic acid to most of us, and it can cause elevated levels of homocysteine. So these are simply blood tests that we do. Again, it's controversial which one should be done and how they should be treated. In our program, we do evaluate for these things, and we will treat with either baby aspirin or a combination of a daily baby aspirin and heparin injections, which is a blood thinner. Kind of makes sense that this could be a cause of pregnancy losses because our bodies need that appropriate blood flow. And if tiny little clots form in the developing pregnancy or the developing placenta, it can arrest or stop the growth of the pregnancy. So I think those are pretty important factors. Even more controversial are immune disorders, such as lupus anticoagulant and antiphospholipid antibodies. Those are blood tests that we do, and about 20% of the tests that we do come back positive for that. And that's kind of across the board, not just in our practice, but in all practices. Things that, and I would treat for that, again, with baby aspirin or heparin. Things that probably don't matter are natural killer cells. I have people call me every week saying, do you treat for natural killer cells? Do you test for that? And the answer to that is no. People either believe in it or they don't. But and most professional organizations and most reproductive endocrinology healthcare providers don't agree on that, and most people don't believe in that either.
Okay, so I don't know what a natural killer cell is.
Yeah, that is an immune disorder. So it kind of does what it says it's going to do. It goes after and kills cells.
Okay.
And so maybe if you have high levels of natural killer cells, it will go in and just see something and recognize it as foreign.
Okay.
In my opinion, as well as others, we have to remember that implantation is a little bit analogous to inflammation.
Mm-hmm.
So our body does have to see the pregnancy, recognize that's something that's not normally in the uterus, and then almost cocoon over it and facilitate implantation and continued development. So you need a little bit of an inflammatory process there.
Right.
For that reason, we don't want people to take non-steroidal drugs like Aleve or Advil or Motrin, those types of medications. The natural killer cells, gosh, there have been some treatments that I don't even want to mention because our professional organizations frown upon them.
I just never heard that.
Yeah, it's kind of a wild name too.
Yes.
Some other things that we might want to do, we already mentioned about genetics a little bit. One of the genetic tests we can do is a karyotype, which maps out your chromosomes. So we can look at every single of the 22 numbered pairs of chromosomes and as well as the sex chromosomes. And we can look, actually it wouldn't be me looking at it, I'll look at the report, but skilled people will look at the karyotype and tell us what is normal and what looks normal and what doesn't. Sometimes you can do tests to minimize the likelihood of if you do have an abnormality, for example, a translocation, you can actually do a biopsy of the embryos to see if they have that same thing that might cause a pregnancy loss. You can look for that translocation and only transfer the embryos that are affected. And should you be unfortunate enough to have another miscarriage, then you want to have genetic studies done on that pregnancy loss. Because with that tissue, we can find out if there was a genetic cause or not, and that might point us in the right direction. The next thing that I would like to mention to you would be about hormones. Our bodies, men and women, are all full of hormones, and they have such a bad rep, but they're actually important in everything that we do, and certainly important for reproduction. So my favorite thing to talk about, as Mallory knows, is hypothyroidism. So the thyroid gland is underactive, and that is a very common cause of pregnancy loss. Mm-hmm. And it's much more common than people may think. So anytime a patient comes to see me, I will do a few blood tests when they first come in. One of the ones at the top of the list is a thyroid stimulating hormone, a TSH level, that evaluates how hard your thyroid gland is that's having to work to make the right amount of thyroid hormone. Now, why is that important? What does the thyroid do? The thyroid gland I consider one of the master glands in the body, and it regulates everything from your heart rate, your metabolism, just your respiratory rate. Everything in your body pretty much is regulated by the thyroid gland, either fast or slow or normal. We know, but based on a study that I published 2 or 3 years ago in Fertility and Sterility, that even women that have normal thyroid hormone, once they get pregnant, those thyroid hormone requirements are increased and they become hypothyroid once they're pregnant. About a quarter of women become hypothyroid once they're pregnant. So in my program, we check everybody with their first pregnancy test. We always do a thyroid test too, because that is something that is easy to check, easy to treat, and hopefully will increase the likelihood that a pregnancy will continue. And that is done on everybody, whether you've had a pregnancy loss or not. Another hormone that can, interfere with pregnancy continuation is prolactin levels. That's another hormone I routinely check. Prolactin is the hormone that is produced most commonly when we're breastfeeding, and it helps stimulate milk production. You may have heard an old wives' tale that when you're breastfeeding, you can't possibly get pregnant. Well, that's a little bit true, and what that's based on is once your prolactin level gets high, it will inhibit ovulation. The thing that's not true about that is once you stop, after you've breastfed for a while, the prolactin level kind of normalizes, and once you start having periods, then you still can get pregnant. Even before you have a period, you can, once the prolactin levels kind of level off. Poorly controlled diabetes is another issue. That kind of goes back to the lifestyle issues that we talked about a few minutes ago. We routinely check a test for diabetes when people come in. That is an easy thing to check. It is a fairly easy thing to treat, and it's an important thing for overall health as well as pregnancy continuation. And probably the last hormonal thing that I think is extremely important is ovarian reserve. So we've talked about this before. We've talked about fertility. What is ovarian reserve? We are born with all of the eggs we'll ever have in our lifetime. Actually, the time that we have the most eggs that we'll ever have is when we're still about 20 weeks inside our mom. And before we're even born, we've lost half of those. Then by the time we have puberty, we've lost half of the remaining. Every month after puberty, after we start having periods, we're still losing tens of thousands of eggs, at least every single month. And as we get older, birthdays contribute to having more eggs that are lost, and having a lower ovarian reserve. So we're running out of eggs, or those numbers are just getting lower and lower. Now, why would that matter? Because as we age, our ovaries age, and those eggs are a little bit older than we are. So I like to think about this in terms of going to the grocery store on a Saturday night and wanting to get fruit. It's kind of picked over by the time you get there on a Saturday night, because the best ones are taken first, and what's left isn't quite so good. Mm-hmm. They're more likely to be abnormal. Same thing with ovarian reserve. Our best eggs are ovulated first. The ones that are left are more likely to be abnormal. So irrespective of age, it's important to know what the ovarian reserve markers are, such as with a follicle stimulating hormone or anti-mullerian hormone. Taking a look, we can tell about the health of the ovaries, and those are either blood test or an ultrasound. I did have a patient when I was explaining this. He said, I don't really get that about the fruit stand, but it sounds like it's your chosen last for dodgeball. And so that kind of makes sense too. I thought maybe that was a guy analogy. So I've kind of thrown a lot of different medical jargony things around, lots of different kinds of tests. It is a lot. It is a lot, and you want to see somebody that is keenly aware of all of these issues that can go on that can keep pregnancies, excuse me, from developing or keep pregnancies from developing normally, and God forbid, that might result in a pregnancy loss. So you want somebody to carefully go through each of these things, find out what you're at risk for, and figure out how to best treat it. But I'll tell you a little secret, and this is my last graph, I think, is this one right here. For women under the age of 30 who have had 3 or more losses, they still have about a 70% chance of taking home a baby after 5 years. And for women older than that, it's between 60 and 70%. So no matter what, have this evaluation done, fix the things that you can fix. You can fix uterine abnormalities. You can evaluate for genetic things, get pointed in a direction. You can evaluate for some of these clotting disorders, maybe for some of the immune disorders. Treat the things you can, have a healthy lifestyle, all things in moderation, and you are still likely to have a continuing pregnancy. The highest number of pregnancy losses I have personally seen one patient to go on to have a continuing pregnancy was 8. And she ended up having a healthy pregnancy without having to take any additional medications. So what do? First thing you want to think about, other than getting a careful evaluation, is find emotional support. I think of the things that people say over the span of my, now into my 4th decade of my career. I think of the things that people have said to me that were hurtful and things that were helpful. One of the things that you may have had said to you, if you've had a pregnancy loss, well, at least you got pregnant, you can do it again. Okay, so maybe that's a little bit true, but that's not exactly what you want to hear. And when somebody says these things, even though it's well-meaning, I think you can communicate back that, yeah, I can't get to that point right now. Right now, I need to grieve. So I think it helps to be honest with people. Also, sometimes folks will offer advice. Well, you shouldn't have been exercising like you exercise. Yeah, that's probably what caused it. Well, sometimes, exactly, gain some weight. We hear these things all the time. That's not what you want to hear either. So my opinion about how to address this and what I tell my patients when they are unfortunate to have a loss or even multiple losses is, even if we can't find out what the cause is, we can rule out that anything that you did caused it. So if you follow those rules about things in moderation, there's really nothing you can do to cause a pregnancy loss. Only in the movies, if you fall down a flight of stairs, do you really lose a pregnancy. And I don't ever want you to feel blame for having a pregnancy loss. Also, I never want you to feel that you can't reach out and ask for help. Ask trusted family, friends, your church, whatever support group system that you have. Blessed Brokenness has amazing support services. We also make recommendations for psychological counseling. Sometimes you need more than just your friends and family can help. Just like you would get help if you have diabetes, you need to get help if you have psychological needs and need help grieving this and working through the process. So before we start with questions and answers, I just want to run through what can you do to either prevent a miscarriage or to minimize the risk that you'll have a miscarriage, or if you've had miscarriages in the past and want to lessen that likelihood. First thing, don't smoke. Next thing, don't have a BMI over 30. If you do, work to bring that down. And remember, every point that you bring it down increases the likelihood that you will get pregnant and stay pregnant. Have a healthy lifestyle, try to avoid exposures, limit caffeine, limit alcohol, take prenatal vitamins. When I think about what prenatal vitamins to take, the 2 things that I think are most important are folic acid. Remember, we mentioned about folic acid deficiency. Folic acid is added into bread, but a lot of people don't eat white bread, or they get bread at a bakery that doesn't add it. It's just commercial loaf bread, we call it, that that'll have folic acid added to it. You can take too much, but if you take a prenatal vitamin, you want to look for one that has 800 to 1,000 milligrams of folic acid. Also, you want to have a prenatal vitamin that has iodine in it. It's kind of the same thing. That is for thyroid health, because so many people had thyroid disorders decades ago, had goiters, and it was because they had iodine deficiency. So for that, the FDA said, oh, we should add iodine to something everybody has, so let's add it to table salt. Well, too many of us are snobby about what kind of salt we use, and we don't use the Morton salt that you get in the big box for, it used to be a nickel when I was a kid. I don't even know what it
I
costs
bought
now.
some for like 39 cents at Aldi's the other day, like a big thing. I was like, they can produce this for 39
Exactly, it's
cents
crazy.
and still make money.
Yeah, the box should cost more than
I
that.
know, I thought so too, but yeah, it's still very cheap.
but now we're wanting pink Himalayan salt and sea salt and kosher salt. Those salts don't have iodine in it. So I think it's important that you find iodine in your prenatal vitamins. Doesn't matter if it's an expensive one or not, but look for a good amount of folic acid and look for iodine in prenatal vitamins. Next, reach out for help physically, emotionally, and to try to find the underlying cause so it can be treated. So I am going to stop there. I have no idea how long I've been talking. I hope it's not too terribly long.
Yeah. No, we've got a good 20 minutes.
Perfect.
To have some questions and answers. I see some coming in right now. So, but please go ahead and post if you have any questions for Karen, and we will do this for the next about 15, 20 minutes, and then we'll wrap it up. But this is always a great time to learn from one another. You all have the best questions. So we'll start with this one, Karen. What are some signs and symptoms of miscarriage? Can it be emergent?
Gosh, that's a great question. I wish I had included that in things to talk to you about. So thank you so much, whoever asked this question. Sometimes women can have bleeding. Signs of miscarriage can be pain or bleeding. Sometimes a sign of miscarriage can be no symptoms at all. And that's one of the scariest things. You come in thinking everything's going to look great, and it doesn't. The pregnancy has stopped developing, or there's no heartbeat. So the things I tell people to let me know about, if they have bleeding that's like a period after they've had a positive pregnancy test, or if pain is worse than menstrual cramps. After we ovulate, the leftover sac that the egg came from becomes a gland that makes progesterone, and it's a cyst on our ovary. So it's normal to have some twinges or some heaviness or some cramping early in pregnancy. It's also not uncommon at all to have some vaginal bleeding. You can have some spotting, or it can be more than spotting. If those things happen, I think you should always err on the side of caution. To me, those are acceptable middle of the night calls. You can call anytime with concern about that. That should be evaluated, both to find out if the pregnancy's okay, but also to put your mind at ease. I don't want any patient to worry that something may be going on or something has stopped developing. So it's easy to take a look at.
Yeah, and I know I just walked this with a friend, and she was having some spotting and some cramping, and she's like, well, I don't want to bother the nurses. I feel like I call all the time, and I'm like, no, that's what they're there for, is to care for you, and that's what they want to do.
Absolutely.
And so, unfortunately, it was a miscarriage, but she was so thankful. She was like, I probably would have just delayed, and a lot of times it's because we don't want to find out that answer, and I get that. But there are reasons to make sure everything's okay. I know my first pregnancy was an ectopic pregnancy, and so I had a really sharp pain and then some spotting, but then it went away. So in my mind, I was like, it's okay. But then I had a consistent kind of constant pain on one side, kind of just that, just a little mild cramp. Didn't even know what an ectopic pregnancy was until I was told at the doctor's office. So I don't know if you want to speak a little to that and what that kind of what to look for in that as well. Because I know that for me that happened at 5 weeks, and that's typically early, but it can also be life-threatening if it's not caught early and not addressed.
Absolutely. So anytime you have pain or bleeding and you have a positive pregnancy test, I always look for the worst, but hope for the best. That's kind of a Benjamin Franklin approach. It is very common that people have both those things and continue a pregnancy just fine. But please call your provider if you have those symptoms to be evaluated. No time is bad to call. Anytime that you have questions about it, please contact your healthcare provider. Sometimes if you've not had an ultrasound or a way to completely evaluate the pregnancy, make sure it's in the right place. You have those symptoms. Those are also symptoms. Pain and bleeding are symptoms of an ectopic pregnancy. Yesterday, I had 14 patients scheduled for pregnancy ultrasounds. It was their very first pregnancy ultrasound after an IVF series, and I just ended up opening up a day that I planned to be out of town, and we just put lots of pregnant people in on that one day. And nobody really was having any problems to write home about. I did ultrasounds, had lots and lots of good pregnancies. One patient in particular had no symptoms at all. She felt pregnant. I did the ultrasound, and the pregnancy looked perfect, but unfortunately, it was not in her uterus. It was in her tube. And could see a heartbeat. It was well developed, and it's heartbreaking to see that happen. Everything looks perfect, but it's in a place that can be life-threatening if it goes any further. And bless her heart, she had to leave my office thinking she was going to have the best day ever, and see her sought-after pregnancy, long desired pregnancy on ultrasound, and we end up doing surgery on her the same day. So that's another reason you want to follow up with your provider if you have any kind of symptoms of pain or bleeding, so we can make sure that everything's okay. And if it's not, we're going to know so we can treat it promptly. The other part of that question is, can a miscarriage be an emergency? And the answer is yes. If you start bleeding, sometimes you'll bleed more and more heavily and cramp more and more heavily. If you're further along in the pregnancy, like beyond 7 or 8 weeks, that can be life-threatening bleeding and continue. So if you have a pregnancy, if you are determined to have a pregnancy that doesn't have a heartbeat, your provider may recommend that you have a D&C to prevent that from happening, as well as, did I answer a question that just came out? To prevent your having an emergency in the middle of the night, or having debilitating pain in the middle of the night. It may be recommended for that, but we can also do the genetic studies on the products of conception to see if there was a chromosomal or genetic abnormality with the pregnancy that caused it. So that was a great question. Absolutely. Great question.
How can a woman know if she has miscarried? What should she do? Okay. Which maybe we kind of talked about a little bit there.
Yeah.
Okay. How many miscarriages should prompt further testing?
You know, as I said, 20% of all first pregnancies end in miscarriage. So that if you have one loss, you are no more likely to have a miscarriage again than if you have than anybody else. That does not increase your risk at all. If you have 2 losses, I think it's time to talk to your provider and say, I'm concerned about this. I've had 2 losses. Let's find out what's going on. Again, it used to be people said 3, but now insurance companies have started to realize that it's best warranted to do an evaluation earlier. And many of these tests are covered by insurance to find out what the causes are.
That is nice to hear.
Yes, and you should always ask, you can ask your provider if your insurance is likely to cover it, and they should be able to help you with navigating your benefits.
All right, we got some more questions, but y'all keep them coming. If you have any, you can type them in the comments section on this live screen. So keep them coming. What are causes of a late-term loss?
Okay, so for a late term loss, so more than 20 weeks, there can be a number of causes too. This is an entirely um, whole new hour of discussion for that. I think the thing that people worry about the most is just an asymptomatic, meaning that you don't have pain or bleeding, but all of a sudden um, your water breaks or you start having lots of pressure and you go in and your cervix is dilated without even knowing it. That's called an incompetent cervix. That can even happen in the second or third trimester of pregnancy. If you know that that's happened in the past, and unfortunately there's no way to predict when it's going to happen, but if it happens in one pregnancy and we know that's what it was, there are things we can do to remedy that. It's called a cerclage, where you put like a little stitch in the cervix and kind of close the cervix to minimize that happening. There are other genetic causes. There are other fetal abnormalities that aren't genetic that can cause pregnancy losses. And sometimes we don't know. Sometimes babies just stop developing. Um, Sometimes people think it's cord accidents, but sometimes we just never know.
And so with the cervix, and I don't, do they call it a short cervix or?
It can be, it doesn't necessarily have to be a short cervix, but it can just, the cervix painlessly opens, painlessly dilates.
Okay, and so would you know that before your pregnancy?
No.
So you kind of have to experience it
That's
first
right.
before you can, treat it.
That's right.
Okay.
Now, I don't want y'all to start worrying. Those people that are on here that have recently found out that you're pregnant, don't think, oh my goodness, I want to check my cervix. I want to get my cervix checked. It's not very common. If it happens to you, it's 100%, but it is not a very common thing. Just be in tune with your body. And anytime you have concerns, you wonder if something just doesn't feel right, it merits a call and an evaluation.
When should a patient switch from a regular OB to a reproductive endocrinologist?
Gosh, that could potentially be a self-serving question, but we are very fortunate in this community, and I know people are on from all over. I see somebody's on there right now that is from out of town, and the OB community in this area is very, very good. Mm-hmm. And oftentimes, if patients have had more than one loss, meaning two or more losses, the OBGYN, the general OBGYN, will recommend that you make that referral. I also think, though, that knowledge is power. If you want another opinion, it's your body. You should get another opinion. Nobody is going to fault you for that. Even if you are in my practice and you want another opinion, I will praise you for that, just like you would. You don't go out and buy the first washing machine that you find, and you don't stick with that same washing machine even if it doesn't feel like it's working. You want to look at something else and see if that might work better or make you feel more comfortable. So same thing with your healthcare provider. Be open, ask questions, ask your provider if they think you need another opinion, or ask to see if there are other tests that can be done, or if you need to see a specialist. They'll be honest with you.
Okay. If I recently had a chemical pregnancy, what can be done to improve my chances again?
Great question there too. So what is a chemical pregnancy? Most people never know that they have a chemical pregnancy. A chemical pregnancy is when implantation tries to happen, but the pregnancy never really gets off the ground and develops. By definition, it is a pregnancy loss prior to ever seeing it in the uterus. Unfortunately, it's more common than we even know. The most common time to have a chemical pregnancy is at the time of her period. When a woman has a period, half of all pregnancies are lost with the period, where just implantation doesn't occur completely or normally. If you have a chemical pregnancy, there's really not anything different that you need to do to evaluate for that. If you've had multiple or more than one chemical pregnancy, that might be something to go down through this list that I just shared with you earlier, to take a look and see what other causes for loss. I don't blow that off if people have had chemical pregnancies. I do think having one is probably bad luck. Having more than one, it's going to still be recurrent pregnancy loss. Now, keep in mind that women that are trying to get pregnant, that are doing fertility treatment, they're going to be doing frequent pregnancy tests. So you will know that you're pregnant if you're really trying and keeping up with it, where other people would think their period's just late and it finally came on. And that's what generally happens with a chemical pregnancy.
Are miscarriages more common with fertility treatments versus natural pregnancy?
Gosh, these are such great questions. I couldn't have written them better myself. And the answer to that is no. It's kind of surprising. Sometimes women that have fertility issues have underlying health problems, like problems with their thyroid or their prolactin levels or diabetes. And those things can lend itself to increased risk of miscarriage. But generally, when you're trying to get pregnant and having fertility treatment, those things are going to be hawked pretty carefully. However, again, we are kind of slaves to those pregnancy tests. We want to test frequently and early, and doing IVF. I have lots of patients who will come in on the day of their pregnancy test and dump out a bag of test strips on my desk and say, okay, these are my AM and PM tests for the last 10 days. I tested out my trigger just to find out if I'm pregnant. And if these colors of blue are a little bit darker, and I finally get one that says pregnant, and can these shades of blue look the same? So you know you're pregnant so much earlier. So it might seem like the pregnancy loss rate is higher, but sometimes pregnancy tests, even if you have a faint positive before you're due for a period, you may not actually have a positive when it's time for your period. So I think it's just because we really closely watch to see, so we can know as soon as possible if it's pregnant.
Absolutely. Okay, one more. I have factor 5 or 2 mutation, and no, I'm gonna let you read this. That's some bigger words than I know.
Okay, so this lady is asking about one of the clotting issues that we had talked about. I don't really want to take the place of your provider by answering these questions. It looks like this person is taking baby aspirin, and I think that is likely the right treatment. You might want to ask your provider if you should also take heparin, but we'd need to see that actual report to see what would be right for you. Now, the only time that you take heparin is going to be either after you've ovulated, if you're doing something like an IVF treatment, or after a pregnancy is established. So talk with your provider, tell them that you have questions about this. Just make sure that no question that you have goes unanswered.
Absolutely. Well, these are great questions. I know one thing that I want to plug, just because I experienced it myself, is when you talked about the different uterine abnormalities. And I know Karen will agree because she just mentioned it. But if you are having concerns or not feeling quite sure what the next plan of action is, if they talk about a procedure or next steps as far as what your uterus looks like, a second opinion is always great. My husband made me get a second opinion, and I'm thankful for that. But sometimes, so often as women, especially if we're in that, we've been going at it for a long time and we're kind of in a desperate state for anything and everything, we'll just say yes, and that's where I was. And so it was so helpful to learn, really educate myself on it as well and be an advocate for myself and get that second opinion. So I think it's just good, Karen has already talked to it about she doesn't get her feelings hurt if you need a second opinion. And I know other providers would want you to as well. So just make sure in those cases, in all cases, that you're just advocating for yourself too and asking those questions. So thank you so much. This was awesome. I know we could talk forever with Karen. It always ends too soon. But we thank you so much for all the information that you always provide for us and for the community and for you ladies. And just know Karen is always here She
Literally.
She is literally here in Birmingham too. So if you need to come visit her, her door is always open, and she would love to meet you if she hasn't. And as well as when Karen was talking to the emotional support, Blessed Brokenness would love to walk alongside you if you don't have that spiritual or emotional support as you're walking your journey. We do have a small group called A Blessed Womb, where we really kind of remove the areas that we can't control and really speak life into your circumstance and just really support one another through this journey. And you can go to our website, blessedbrokenness.org, to get some more information, or reach out to us at support@blessedbrokenness.org, and we'd love to have a one-on-one conversation with you. We are in the middle of our small group right now, but we'll start at the beginning of next year, 2021. We are virtual, so anyone and everyone can join, and it's really been a very successful, very cool process to see that intimacy and that safe environment can still exist even when we're across the screen with one another. So we invite you to join us, or just reach out to us, and we're happy to support you right here and right now, even though our small group has already started. And I don't want to forget that we do have a giveaway. So Miss Karen has also so graciously donated a free consult to anyone. And also, if I know we reach across state lines and not everybody lives in Birmingham, and that's okay, because with COVID we learned that we can do things virtually.
That's right.
And it works well. So, and even if you are here in Birmingham and you don't feel comfortable coming into the doctor's office, then Karen will set up a virtual appointment with you as well. Karen, what do they need to do? We have a certificate that we'll mail to you, but just call your office to set that up.
That's
Reference right. Blessed Brokenness.
That's right.
And
call and ask for my receptionist, Caitlin. She knows about this. They'll announce the winner of the raffle tomorrow on the Blessed Brokenness Facebook page.
Yes.
Is that right?
Yep, and Instagram.
And we'll also notify you if you are the recipient of the giveaway, and you'll just be given the phone number to call my office and ask for Caitlin, my receptionist, and just reference that you won the giveaway with Blessed Brokenness from tonight, and she will be happy to make that appointment and just bring the certificate in when you come.
Awesome. And so if you haven't said hello to us through the comment section, please do so now so we can make sure and get your name in the drawing. And like Karen said, we'll be doing that tomorrow, so check out our Facebook and Instagram page at Blessed Brokenness when we announce the winner. But it's such a great donation and gift because one, we know these things are expensive, and two, just a wealth of knowledge right here to ask any and all questions that you have. So thank you so much.
You are so welcome. And keep in mind that everything just starts with a conversation, and when you do make an appointment to see whatever provider you choose, it's just a conversation. Knowledge is power, and you want that power at a time when you really feel powerless. And I don't know if you can see this or not, but I have a patient who gave me this beautiful necklace that's a cross, and inside the cross is a mustard seed. So remember that if you have the faith of a mustard seed, all things are possible, and speak it into existence. And know that we're all here for you.
Oh, I love that. That's so good. What a great closer. Thank you.
Thank you for listening to the Fertility Talk series hosted by Blessed Brokenness. To join a small group or apply for fertility scholarship, visit our website at blessedbrokenness.org. We hope you will join us for our next Fertility Talk, available every second Monday of the month.